Thank you for joining us for Conversations in HIV, Patient Voices Guiding Physician Choices. During this segment, we will be discussing my patient, a cisgender woman with HIV and a history of substance use. I am Dr. Amasika Niaku, Associate Professor in the Division of Infectious Diseases at Rutgers, New Jersey Medical School, and I'm very pleased to be joined by my colleagues, Dr. Clement and Dr. Wall. So I want to tell you all about a patient, one of my many wonderful patients who we have, over the last 5 years, I've been taking care of her, and I just think that there are a lot of clinical insights that can be gleaned from her course. So I actually originally started taking care of her before she was diagnosed with HIV. She had been hospitalized because she had a very severe right upper arm abscess that required multiple incisions and drainage. So at that time, we talked about her going on PrEP, but she felt that the severity of her infection, that had really been a wake-up call for her in terms of her substance use. And so her perceptions of her HIV risk at that time were greatly diminished. She did have fairly significant anxiety disorder as well as obsessive compulsive disorder, so she did need more intensive psychiatric care. However, she had difficulties linking with that program, and later I found out that so she fell out of care and then eventually stopped being on medications for opioid use disorder. So now I want you to hear from her about getting diagnosed with HIV.
I went to the hospital. I was on the streets. I went to the hospital. I had fell back. I'm assuming this is going to be from fentanyl. And which I've done many times, I passed out like a domino. I just fell over and I broke 3 of my fingers. So I got to the hospital, and they kept me overnight or whatever. And that's when they let me know that I had tested positive. So my thoughts in that moment were like, my life is over. I had just lost my fiance prior to this. So I was just, I left the hospital AMA. Now, and of course, my mind is totally crazy at this point because back on the street, I'm back on drugs within 24 hours a day, just trying to numb everything. And then I'm like, I can't be out here doing this because I'm part of the problem now.
So I wanted to find out about your HIV testing programs that exist in some of the other facilities outside of your infectious disease programs. What does it look like?
Yeah, so we have opt-out testing in our emergency department, which I think has really been incredible. We've had a lot of new diagnoses and very quick linkage to care from as a part of that program. We also have, a lot of education going on in primary care, and so robust testing as a part of primary care appointments. We have an integrated health clinic for addiction management, and they're doing HIV testing. And actually, we're seeing more of these providers getting really excited about PrEP too, which is exciting for us that we're having greater uptake of not just patients, but physicians, right? Primary care and other providers who are either referring to PrEP or actually prescribing it themselves.
On the other hand, where I live and work, I don't think I could say that we have a robust system. I think that there is probably some centers of excellence where there's really good ability to get HIV tested and where providers are really thoughtful about this. But I would say by and large, we're clearly underdiagnosing or detecting HIV. And I think that that's been a problem for a long time. And we don't have a comprehensive emergency department program at most of our major facilities, even though we've done, and our colleagues in the state have done research on this. Our correctional system probably does the best job of this, offering HIV testing to people in prison, state prison, not in jails, which would have been optimal. So again, there's some good news, bad news there. But this points to this is just a broken model and why we need things like thinking about like home testing.
Yes, yes. And it still ends up being a work in progress because you can have the testing, but then if there are issues with the linkage, or then if people are linked, but they have the, various transportation issues or other psychosocial issues that mean they can't get from point A to point B, right? So there are all of these different parts. And like you said, there needs to be more innovation present in the way that we're doing our diagnosis to be able to account for all of the different circumstances that patients have. So after my patient was diagnosed, so before she left the hospital, they gave her an appointment and they put her on my schedule so that she could see me again because they saw that she'd seen me previously to treat her arm infection. So I remember seeing her pop up. I remember, pre-charting on her and seeing, oh, she's been now diagnosed with HIV. And so I waited. You go through your clinic day and she didn't show up. Well, let's hear why she didn't show up.
So long story short is I was supposed to show up to see you the following week. It did not. But I kind of did because I got hit by a car that day. And that night I did show up to the hospital, as a matter of fact. And that moment changed my life entirely. Okay, so it's immediately when I came to in the hospital, my legs were in stirrups. I didn't know what happened because I still have no memory of the accident. But so when I woke up, I was like, my life, it's over, right? Like not my life, but like this is over. Like it's time to get your life together. So I knew that inside. So I was welcoming any medication to treat it. And then I was more informed about, you informed me more about, listen, you can live with this. There's a way to treat this. And that gave me hope. I was like, oh, you can be undetectable as long as you're taking your medication. So I from that point on in the hospital, I had many days in casts from my ankles to my waist, a lot of time to think.
So this coincides with the pandemic. And as she explained, she was unable to walk because of how extensive her fractures were. So she ended up having to go to a subacute rehab facility so that she could get her physical therapy and get cleared to be able to weight bear and all of those things. So we ended up doing her first kind of initial visits were telehealth based visits. So I think that this is a good time for us to chat a little bit about telehealth visits for HIV care.
Yeah. So during the pandemic, this was critical, right? I mean, patients couldn't come in, didn't want to come in, sometimes needed to come in, right? If they had an acute need, had a physical issue that needed to be examined. But in general, I think telehealth saved us. And it was so nice to be able to manage patients in that way.
Yeah, and I would say also another silver lining, although there's not too many from the pandemic, was our finally ability to embrace telehealth, because people had talked about it a lot, but it couldn't get paid for, we couldn't bill. All of a sudden now we find out we can do it. And there are codes in Epic and all these sorts of things we could do now that we were told we couldn't do before. So I'd say a legacy of that is I definitely still have folks that I now see only through telehealth.
So now I want us to fast forward because she ended up having a full recovery from her fractures. And so she was discharged from the facility back to community living. So then we resumed in-person visits. She didn't have any problems with her ART, was doing well. She was fine on her buprenorphine naloxone for management of her opioid use disorder. And she was seeing psychiatry for her anxiety as well as her obsessive compulsive disorder. And so things were going very well for her. And then she called me that she had taken a home pregnancy test and thought she was pregnant. So we had a discussion. So this was back in, fall of 2022. And like I said, she was on a bictegravir-based regimen. So we had a discussion because at that time, the guidelines didn't have any guidance about bictegravir, except we don't have data for its use in pregnancy. So she ultimately decided to switch.
And I know this took place a while ago, so there's been more data. And a lot of the data aren't like, well, we're going to enroll pregnant people and see what happens to them. But there are studies where people have become pregnant on the study and on the drugs, and we have now, I think, a little bit more confidence in things like BF-TAF and maintaining that and doing that safely. And I think that makes a lot of sense. I think the data are pretty supportive that we can have continued this person on BF-TAF, but I think what you did is what a lot of people would do.
So now I want to take you to the topic of breastfeeding, because that was something that came up. And that is important for us to understand for people with opioid use disorder that are on medications for their opioid use disorder, that there can be neonatal withdrawal syndrome that occurs. But at the time, so this was, like I said, fall of 2022, which then took us into the summer of 2023, breastfeeding in people living with HIV in high-income countries was not a part of our recommendations. And so I want you to hear from my patient her perspective of thinking about how she wanted to move forward.
My pregnancy was, I made every appointment. I was like, now I'm responsible for another life. Like, forget me. Like, there's another human inside of me. And so I went every visit, took my medication religiously. I had a beautiful, healthy girl. There was a lot going on in that last 2 years. All of a sudden, my life has completely changed.
We spent a lot of time talking about whether or not you were going to breastfeed.
I'm glad you brought that up, because I believe, talking with you, and just correct me if I'm wrong, the best option is probably not to breastfeed, but it was always up to me, right? Up to me. There's always a chance. There's always a chance. So if there's a chance, I'm not doing it. And then I hear from somebody else who was like, you can breastfeed if you want to, or you can't. And then I'm like, I need a straight answer. But even if there's a marginal risk, I'm going to play on the safe side. But yes, it was disappointing that I could not breastfeed. So I think it's situational. And, what's the exchange rate here? The chance that my daughter might be exposed to something, or me being hurt because I can't breastfeed and be close to my daughter. But I'm with her every minute of every day. So how much closer do you want me to be without risking her life?
So this is, I think, still pretty early to understand how people are kind of changing their practice or changing the way that they advise patients about this. But I'm curious to hear your thoughts about how you approach this discussion about breastfeeding in somebody living with HIV who has durable virologic suppression.
Yeah, and I just want to recognize for a second how insightful your patient is. Every time I hear her speak, I'm like, she's so thinking about others who might be exposed by drug use, or her baby who might be exposed, and whether or not to breastfeed. She's so thoughtful. But these are really tough discussions. But so I think you go through the data and you talk through the pros and cons. And maybe you provide all the education and you support them in whatever they decide. But if you do feel them that kind of itching for some guidance, I think it's okay to give guidance, more stringent guidance, I should say.
Yeah, and I have no expertise to tell you about what we should or shouldn't do in this particular situation. My expectation would be that there is pretty much no risk of transmitting this virus as long as she maintains on HIV therapy.
I think it's less than 1%. Right?
Yeah, I mean, I would have a hard, because we talk a lot about U equals U.
Right.
I think if U equals U, then I would expect breastfeeding, chest feeding to be the same thing. I don't know that there's data to suggest that it should be otherwise. So I think we could give her, but there's the reality and also the perception, because if she's, and I'm not saying in this case she would be, but if there's a perception that there is a risk, even infinitesimal, that could weigh on her, especially with her obsessive compulsive disorder. So I think there's a lot of balance here, but probably biologically, there's nothing to be concerned about, but I think we have to acknowledge her concerns and support her either which way and just give her the data.
And I think that the reality of her decision making was the fact that there was not a unanimous decision between myself, the OBGYN and the pediatric, the pediatric infectious disease specialist. So because we weren't all saying yes or all saying no, and that there was differing through that's why she was like, well, if you aren't all saying yes, then I'm going to go with that no, because of that other part that I don't want anything nagging at the back of my mind.
Well, and it's interesting, right, that WHO guidelines and the British guideline, like there's conflict there too. So I think we don't have a firm consensus.
Right. So last we wrap up that, looking back at her course between PrEP and then her being on her bictegravir-based regimen, she's remained on her 2-pill once-a-day dolutegravir with FTAF regimen, even though I've offered for her to go back to her co-formulated single-tablet regimen, and she has elected not to. And so I, will talk about this as the magic wand. I gave her the magic wand to tell me what she thought would be an ideal regimen, and so I wanted you all to hear about that.
So I'm aware that you can get a shot every few months. I'm aware that I'm taking 2 pills instead of 1. For me, ideally, the 3 months is great. You don't have to go see somebody's match or maybe whatever, and you don't have to think about it. But every time I take my pills, it is a reminder of what I have to deal with every day. And I personally need that. I have a responsibility to myself and my family now. And those pills and making sure I go pick up my prescriptions physically once a month, that is what works for me. And that's magic wand. Yeah, I wouldn't, if I had a magic wand, I would certainly, I would go back to the beginning, but this is the perfect regimen for me. And if anyone who's wants to save their life and wants to do the right thing, it's a great reminder of where you were. It's a great reminder where you are. And it's a great, it's inspiration that you're well and that you can continue to move forward with your life.
And so, so she talks about injectable treatment, and we've talked about, that it's every month or every 2 months, that is an option. And again, like she acknowledged, we've talked about going back to her single tablet regimen as well. And hearing her talk about how she's weighed the different options has been a very nice reminder to me about that as we're constantly thinking about moving things forward, having our patients on the most updated regimens and all of those things, that there is comfort in the familiarity, right? And so people can be optimized in different ways than, what we normally think about. So there was never any desire for there to be a one size fits all.
I just think it's interesting. She likes that daily reminder. I have many patients who do not like that daily reminder. That is why they want injectables. And I actually really enjoy hearing that this is she's owning it, right? This is her daily reminder of what she needs to do to be responsible for her own health and for her family's health and family's well-being. And so, again, this is a really insightful woman, and I really enjoyed hearing from her. So thank you.
Yeah, and I think it teaches us we have to be really careful about generalizing about our therapies. Taking an injection is what people want. Or is more convenient for people, or is more desirable. It's more desirable for a lot of people, maybe the majority, but not everyone. And I think in her case, taking the pills, and she's purposely, it's almost like afterload, for a muscle. It works better with a little bit of load. And I think for her, she's feeling taking 2 pills rather than 1 pill puts a little bit more burden on me, and I'm going to shoulder it. And I don't want things to be too easy, because if they're too easy, I think in her mind it might be I could slip back. So let me make it a little bit, I'm going to be a Marine, right? And I'm going to tough it out, and I need that to keep me straight and narrow. So everyone's different. Really be careful about these generalizing studies that show that most people in clinical trials of an injectable want an injectable. There's a lot of diversity out there, and I think that we need things that fit people where they are at that moment. And she could change. Right. When her daughter's 5, she may say, you know what, I don't want to take 2 pills every day. And we need that flexibility.
Agreed. And that's a little bit too, like you said, about her not only needing this daily reminder, but she expressed a certain amount of, I don't want it to be too out of sight, out of mind, because then you can forget what has happened and why you're in this place. And so she has some remarks about that. And then she also added the part, we've talked a lot about polypharmacy, but she also did add the part that she's already taken several psychiatric medications. And so for her, when we talked about going from the 2 pill to once a day, she was like, this one additional one is like a blip on her radar. So I think we've, over the course of our sessions, have talked about patient resilience. And so again, I think that she also underscores just the power of the resilience of our patients. And so, and like you said, not making any assumptions about what we think makes sense, because there's always such beautiful insights that our patients are able to give us. And so I am so grateful to my patient for being willing to participate. I also want to thank you all for being here and giving me your insights. And for the viewers, thank you again for joining us for this segment. Please be sure to click on the landing page for this activity to claim your AMA, ANCC, ACPE credit, access supplemental slides, as well as other topic segments and case scenarios.